Now we will start postgraduate course, Fibrosis Cirrhosis, chaired by Professor Tawasak Tanwandi, Professor Lai Wei, and Professor Gamal Shiha. Moderators, please start the session.
Thank you. Good afternoon. Welcome back to the last sessions of the postgraduate course for Room 3. My name is Tawisak Tamandi from Bangkok. Together, co-moderate with me is Professor Wei Lai, the president-elect of the Apostle from Beijing. So we're going to start with the and this session going to cover on fibrosis and cirrhosis. And the first speaker is Professor Norifumi Kawada. He is from here. His home is here, Osaka City University. He's going to talk on unrevealing progressions of genomic abnormalities in HCC. Professor Kawada, please.
Thank you. Thank you, Mr. Chairman and colleague. It is my great pleasure to give a talk at Absolute Postgraduate course. I will give a talk on liver fibrosis and cirrhosis, molecular and cellular mechanisms of the development and regression of liver fibrosis. I have nothing to disclose. So this is the agenda of my talk today. First, I am going to talk about anatomy of the liver and the history of stress cells. So end-stage liver disease, such as cirrhosis and hepatocellular carcinoma, is derived basically from chronic hepatitis and cirrhosis, although there is evidence that MAFD and idiopathic cases are slightly less likely to have liver cirrhosis. Therefore, it is very important to understand the molecular events underlying liver fibrosis. So here you see the anatomy of the liver. To understand the mechanism of liver fibrosis and cirrhosis, we need to figure out the anatomy of the liver. Liver is basically consisted of hepatocyte and bile duct epithelial cells and hepatic sinusoids. Hepatic sinusoid is composed of L6, Kupffer cells, pit cells, and hepatic stellate cells, vitamin A storing cells. I will mention a little bit about the history of hepatic stellate cells. In 1876, anatomist Carl von Kupffer first described the presence of stellate seren, a star-shaped cell around the sinusoid. However, in 1898, he reversed his previous statement by stating the cells were endothelial cells, L6, that phagocytosed erythrocytes. This leads to the confusion about the stellate seren's history. So in 1951, a Japanese anatomist, Professor Toshio Ito at Gunma University, confirmed there were cells in the human liver that stained red color with STAN3 staining. And he named these cells fat-storing cells. Later, it was also called Ito cells. So in 1970s, Professor Kenjiro Wake, by using vitamin A fluorescence microscopic observations and Golgi's silver staining method, he proved stellate seren described by Carl von Kupffer and the fat-storing cells described by Ito are identical. As you see in the right panel, Professor Wake also demonstrated the clear structure, 3D structure of hepatic stellate cell, and you can recognize stellate cell envelope and capture the sinusoid with the long developed well developed cytoplasmic processes. So, according to his achievement, he was received EASL International Recognition Award in 2017. So after that, isolation technique for stellate cell was established through the effort of Nook and colleagues. And then, as you may know well, Scott Friedman was first to reveal the stellate cell are the principal cell types in the liver that generate extracellular matrix materials like collagen and fibrillin and fibronectins. Since then, researchers on stellate cell and liver fibrosis has progressed rapidly until now. So then I'm going to talk about molecular and cellular mechanism of liver fibrosis, cirrhosis, and portal hypertension. So in case of liver injury, activation of coagulation cascade takes place, and inflammatory cells infiltrate into the site of hepatocyte damage. And they secrete multiple mediators like interleukin-6, TNF, TGF-beta. In response to these mediators, the stellate cell become activated and they generate extracellular cellular matrix materials, including collagens and fibronectins. In case of chronic liver injuries, as you see here, persistent myofibroblast activation and continuous production of TGF-beta takes place. And finally, this process leads to the fibrotic scar healing of the liver. So activated stellate cell become proliferative cell types, and they acquire contractility, they generate extracellular matrix protection, and furthermore, they are the good source for inflammatory signaling. Also, they are now known as an important factor for developing cancer microenvironment. In resolution stage, stellate cells are also known to undergo apoptosis, senescence, or inactivation. Activation of hepatic stellate cell is triggered by a wide variety of mediators created from damaged hepatocyte, bile duct cells, platelet, and immune inflammatory cells. Furthermore, as shown in the right panel, progress is being made in elucidating the intracellular signaling activated by these stimuli and the corresponding nuclear receptors. Furthermore, recently, participation of neutrophils are qualitative and quantitative changes in immune cells and capillarization and the dysfunction of L-sex are also involved in the pathogenesis of liver cirrhosis. So analysis of such kind of cell-cell interaction within the liver is important for understanding the overall picture of fibrotic reactions. Recently, remarkable advances in single-cell RNA-seq technology have enabled detailed clustering of liver constituent cells. As a result, as shown in the right panel, macrophages and endothelial cells related to the septum of liver cirrhosis were identified, and their involvement in the progression and regression of liver fibrosis has been pointed out. So next, let's consider portal hypertension. So in cirrhosis, TGF-beta stimulated activated stellate cells deposit collagen in the space of this cell and acquire contractile properties by stimulated by endothelin-1 and angiotensin II. And the defenestration of sinusoidal endothelial cells takes place under the exposure to VEGF, leading to the increased intrahepatic vascular resistance. Taken together, sinusoidal portal hypertension occur in cirrhosis. On the other hand, in mesenteric and peripheral vasculature, intestinal bacterial overgrowth and translocation are also involved, resulting in the decrease in vasoconstrictor endothelin 1 and angiotensin 2, but nitric oxide increase is induced. This causes dilatation of peripheral vasculature and induce so-called hyperdynamic circulatory status, which is involved in various complications of liver cirrhosis. So next, I'm going to discuss why does hepatocellular carcinoma develop from liver fibrosis. So after hepatic injury occurs, there is necrosis followed by the hepatocyte proliferation. Continuous such necrosis and proliferation process foster a chronic liver injury leading to liver cirrhosis. Subsequently, hyperplastic nodule are observed, followed by dysplastic nodule, and ultimately hepatocellular carcinoma. During this course, telomere shortening and loss and/or mutation of p53 and oxidative stress induced genomic instability characterize hepatocarcinogenesis. So as you see here, the fibrotic liver can be set as store room of growth factors. Activated stellar cell, myofibroblast, inflammatory cells, L6, and damaged hepatocyte triangulocytes generate a large amount of growth factors like EGF, FGF, and so on. And these receptors bind to these growth factors and the mediators bind to the growth factor receptors expressed in hepatocyte, and this ligand receptor binding stimulate into a cellular signal cascade like MEK-L pathways. In addition, produced superoxide analogs and peroxynitrite triggers genomic instability of hepatocyte. So in such a process, finally cancer cell is originated and propagated by using developed cancer microenvironment caused by angiogenesis, inflammation, and fibrosis. So let's think about TGF-beta. TGF-beta is a very important mediator for liver fibrosis, and hepatic stellar cells are the main producer of TGF-beta and induce the proliferation and activation of both MDSCs and Treg cells via secretion of amphiregulin. In addition, L6 liver sinusoidal endothelial cells are responsible for TGF-beta dependent hepatic Treg cells induction and generate CXCL16 and control the accumulation of CXCL6 plus hepatic NK T cells. And furthermore, TGF-beta directly modulate Treg cells, upregulating cell activity and promoting proliferation, leading to CTL exhaustion. So TGF-beta is a very important mediator for modulating immunological reaction in the liver. And furthermore, regarding VEGF, also enriched in fibrotic liver, VEGF induced tumor angiogenesis, resulting in the malformed and malfunctional tumor vasculature. Tumor endothelial cells exhibit immunosuppressive molecules such as PD-L1 expression, which enhance exhaustion of and apoptosis of T cells. So I will not go into detail in this aspect. VEGF contribute to the development of immune suppressive tumor microenvironment. So then let me tell you about cytoglobulin expressed in a hepatic stellate cell, which was discovered in our laboratory. Cytoglobulin is expressed in hepatic stellate cell, and the structure is very similar to myoglobin and neuroglobin. Cytoglobulin was known as a gas-binding molecule and also function as antioxidants. When cytoglobulin is deleted in knockout mouse, as you can see here, cytoglobulin knockout mouse show the augmented fibrosis development and cancer development in then-treated or CDA-treated mice. And furthermore, in case of MASH liver, as you see here, the cytoglobulin expression is almost undetectable in advanced fibrotic liver in MASH patients, and also cytoglobulin gene expression is almost disappeared in liver cancer area. So now we are challenging to further analyze the role of cytoglobulin. But at least we can say a loss of cytoglobulin in hepatic stellate cell contribute to the fibrogenesis and tumor microenvironment development. So finally, I will discuss about the regression of liver fibrosis and portal hypertension. So cirrhosis was previously considered to be an endpoint of liver disease. However, recent clinical evidence has clearly clarified withdrawal of the injurious agent can allow remodeling of the fibrillar matrix, leading to attenuation of liver fibrosis. So, as I mentioned in the first half of my talk, stellate cells are also involved in the resolution of fibrosis by causing deactivation or apoptosis. So this slide shows the mechanism by which antifibrotic therapies may lead to the fibrosis regression. In this talk, I will mention about number 1 point, disease-specific therapies that control or cure the underlying disease or the effective antifibrotic approach. For instance, hepatitis virus B is controlled by nucleic acid analogs, and SCB is eradicated by DAAs. So this is the paper from Taiwan, which showed the effect of 40-week tenofovir treatment on HBV caused liver cirrhosis. The result clearly showed tenofovir treatment is associated with long-term histological improvement, including reversal of cirrhosis in Asian patients as well as non-Asian populations. Already in 2000, a study conducted by Japanese group demonstrated regression of liver fibrosis took place in patients achieving SVR in interferon-treated CSC patients. The Ambrosio reported in 2012, after 5 years from SVR by interferon therapy, cirrhosis regression was observed in 61% of the patients, and the collagen content decreased in 89%. So here you see the typical image of liver fibrosis before or after treatment of DAA. So before SCB treatment by DAA, you see a green stained activated stellate cell presence in the liver. This means hepatic stellate cells are going to generate extracellular matrix materials, including collagens. However, when hepatitis virus C is removed by DAA treatment, as you see, green colored activated stellate cell number is dominantly, remarkably decreased. So as such, the eradication of virus from the liver contribute to the regression of liver fibrosis. So this is a well-known review article published in Gastroenterology 2019 and shows long-term benefits of DA treatment for SCB cirrhosis. So as you see here, the many words regression, reduction, and reduced avoidance can be seen. So eradication of hepatitis virus C contribute to the regression or portal hypertension, suppression, and etc. Even in the cirrhotic liver. So ladies and gentlemen, this is a summary of my talk. Stellate cells contribute to the fibrosis progression and regression in the liver, and regression of liver fibrosis cirrhosis occur when pathogens are removed, and which is involved in the activation and apoptosis of activated hepatic stellate cell. So antifibrotic therapies target to inhibition of fibrogenesis and inactivation of stellate cells are currently under clinical investigation. We are waiting for coming a new drug for anti-fibrotic therapies. And these are my colleagues for my research. Thank you very much for your attention.
Thank you very much, Professor Kawada. We're going to have Q&A at the end of the session. So,
okay. Thank you.
I'd like to pass my microphone to Professor Wei Lai.
Okay, it's my honor to introduce the Professor Jia Jidong, the pastor and the president of PASO. Professor Jia is also the professor from Beijing Friendship Hospital, Capital Medical University. So, Professor Jia, please.
Thank you, Professor Wei, for your kind introduction. Also, I would like to thank Professor Shina to invite me for this excellent meeting. After more than 3 years online meeting, now we finally see in person. That's more important thing than the meeting itself. So today, my topic is non-invasive evaluation of liver fibrosis or cirrhosis. This is my disclosure. Well, it's well known that all chronic liver disease will cause necroinflammation, fibrosis, liver cirrhosis, may also finally progress to ICC, as the previous topic have nicely illustrated. Before, we believe this is a one-way journey, but now we understand as the removal or the control of the etiology, at least early cirrhosis and fibrosis could reverse. So nowadays, the dynamic evaluation of fibrosis and cirrhosis become very, very important in clinical practice. So now this slides is a little bit of busy slides, but just talk about the method to evaluate liver fibrosis and cirrhosis. First of all, it's a hard endpoint, the clinical outcomes, the development of cirrhosis, decompensation, and ICC, liver transplantation or death. Or another way, regression, recompensation, regression of cirrhosis and fibrosis. But this takes a very, very long time, may also need a very large sample size, large number of patients to observe. So it's not actually practical in the short term for clinical study. And so-called surrogate markers or endpoints include histology. Histology has been regarded as a reference or gold standard as the staging. However, the traditional staging also subject a lot of problem, like it's invasive, it's a high inter-observer and even intra-observer variability. And also, of course, the sampling error is a big problem. Nowadays, with the computer and maybe machine learning and artificial intelligence, we can improve the interpretation of histology. Still, we need some non-invasive or minimally invasive with hepatic vein portal pressure, and endoscopy is partially invasive. So finally, we need to have non-invasive ones, which can be easily used in a dynamic manner. So we have many ways. Here, I just showing you some ultrasonography or MRI-based technology. Here, I will explain later. Then also we have the serum, the blood test-based markers. And also we have the combination of the both. So because of limitation of time, I just focus on the this part, not touch the serum. For the liver stiffness measurement by shear wave elastography can be divided into two. One is ultrasonography-based modality. Well, first one is so-called vibration-controlled transient elastography, VCTE. Now it is called. It is the most widely validated and also most widely used modality for non-invasive measurement of liver stiffness. Of course, another one is called ARFE. Well, they also divide into point shear wave elastography or 2D shear wave elastography. This is also maybe have a similar one, but is less well validated and not widely used. So another one, of course, is MRI-based modality, so-called magnetic resonance elastography, MRE, which is cost, but is more accurate than this ultrasonography-based ones. So first, let's start to the ISM by VCTE, which actually this study, multi-center study, conducted more than nearly 10 years ago in China. You can see that's the in hepatitis B patient, nearly 500 patients. We can see the staging of the fibrosis, histological fibrosis, is correlated with the liver ISM, I would say. Then this slide showing if you use this as a cutoff value, you can identify those with significant fibrosis or with cirrhosis. Of course, for cirrhosis, you have better area on the curve, nearly 0.9. For identifying significant fibrosis, they have area on the curve around 0.8. So this is a validation, big cohort validation in China. Furthermore, in our group also, we found that this technique can also identify or predict the histological progression. So we see after half a year treatment with antiviral therapy, if the patient have a very rapid decrease in LSM, then they have a high proportion of patients with liver histology reverse, fibrosis reverse, compared with no reverse group. Then this is by Ishak. This is by Ishak and also the Beijing classification by Professor Yu. So the similar trend. That means the rapid declining at the 6 months of treatment could predict the 1.5 year histological regression of liver fibrosis. Then furthermore, also in our group, we this kind of changes of LSM by VCTE could also predict the clinical outcomes. Here we see liver-related events like decompensation, LCC, death, or liver transplantation, this kind of thing. This is this group is with liver-related events. This is without. You can see in those without, the declining of the TE is much more dramatic than the other one. While this is divided, this is overall, this liver-related events, this is decompensation, LCC, and those without liver-related events have a similar trends. So again, showing ISM could predict the long-term outcomes. Now that's in hepatitis B. What about alcoholic liver disease? Alcoholic liver disease, of course, a little bit complex because stop drinking itself is effective. Here we showing their the dotted line showing their stop drinking, the solid line showing the continue to drink. Whereas there are two measures. One is drinking stop or not. Another, of course, is a baseline TE. You can see we don't need to take care about details, but what we can see is in either group, in whether patients continue to drink or stop drink, the baseline liver stiffness could predict the long-term clinical outcome after 7 years follow-up. You can see so the similar thing. So what about the NAFLD? We can see that's a NAFLD. We can see the changes of LSM by VCTE could also predict the liver-related events in NAFLD. Here are still, because the literature originally used that. Although the first part of this postgraduate course have a lot of discussion on the terminology. So we can see either decompensation, the HCC development, death or liver-related death is correlated with the changes of LSM. If you have increased SM, of course, the incidence of these unfavorable events would be higher. Then we can see that's also for somehow they changed. We cannot see that. This is in clinical trial, clinical trial data by Albetic acid for NASH. We can see this is placebo group. What I would like to see is then the patient, most of patients may have increase in their liver stiffness, whereas in the treatment group, some of them have decreased. So meaning indicating this kind of dynamic changes of SM could be also used to reflect the therapeutic efficacy. So now I would like to turn to another major technique we use, the MRE. MRE could also predict the NASH fibrosis or cirrhosis. Well, instead of just take a very small part of the liver measuring that, then for the MRE could measure the whole liver or at least the right lobe of the liver. So it's more accurate, more reliable, can also be avoid some confounding factor like obesity and other factors. So we can see here, this is a very good summary of that. For each 1 kappa increase in liver stiffness measured by MRE, the non-cirrhotic NAFLD patients have 3 times more likely to develop cirrhosis in the future. That means in non-cirrhotic patients, this could predict the cirrhosis. Whereas in already those already have cirrhosis, 1 kappa increase in liver stiffness could predict they have much more. They have 32% more likely to develop decompensation or even die in the next 5 years. So again, showing this is the MRE could predict the long-term prognosis in patients of NASH with or without cirrhosis. So this slide just schematic showing the classification of the staging of F1, F0, F1 to F4. What I would like to say now, different hospital, different institutes have their own cutoff values, still not have unified, not standardized. So here, this slide just a meta-analysis showing the comparison of the share wave elastography and MRE in NAFLD patients. So it's a little bit complex, but what I like showing is all 3 techniques, ultrasound-based techniques, have less accuracy than the MRE. So you can see the area on the curve more than around 0.9, whereas for the others, the area on the curve between 0.7 and around 0.8. So again, showing, of course, this is more expensive, not easy to conduct, so not widely available. But this is available and cheaper, but less accuracy. So that's the trade-off. Oh, that's also reality of life. Here is an individual patient data meta-analysis to determine the cutoff values and confounder of NAFLD with MRE. You can see this is the cutoff values according to this meta-analysis. They try to standardize or not standardize, try to summarize these things. While you can see also as the fibrosis increase, then the accuracy, the area under curve also slightly increased from 0.8 to over 0.9. Again, showing this is a better methodology in staging fibrosis in patients with NAFLD. Well, again, MRE could also predict the long-term clinical endpoints in NAFLD patients. In this study, use the composite outcome like varices need treatment, or ascites, or hepatic encephalopathy. So it's not completely decompensation. Variceal bleeding, but it's not variceal bleeding. Variceal need treatment. That means maybe large or high risk varices. So from this, we can see the similar thing. Then the MRE, the baseline MRE, of course, you can see the lower, of course, the better. But they use different color code. I would use this green, this is red. Here we see red is not good. But here you see the green one is the higher at the baseline. So again, showing this is could be a predictive. Then this study, also this very good summary of that, you can see the changes in the serial LSM by MRE could also predict the outcome in NAFLD patients. Again, this is in patients without cirrhosis at baseline. This is patients already have cirrhosis. So this in this group of patients without cirrhosis, after around 3 years, less than 3 years, you can see the non-progressive and the progressive. You can see the differences to cirrhosis. This is to decompensation or die. So similarly, we can see the baseline MRE measured SM could predict the progression to cirrhosis or to decompensation. So now we also have some studies it's post hoc analysis for the NASH studies. A lot of them didn't really reach the primary endpoint, but the post hoc analysis or subgroup analysis also showing some meaningful results. We don't need to care about the treatment itself, but what we need to know is that this patient with paired liver biopsy and a paired MRE measurement for liver stiffness. You can see that's the baseline. You can see the baseline MRE values, of course, correlated with the stage. Then most importantly, the after treatment, that's a non-responders, clinical responder or biochemical responder or histological responders. You can see that's their MRE SM value. This is a responder. It seems perhaps there is a trend. Those with response, their liver stiffness measured by MRE could also decrease. So lastly, very quickly, we see this kind of invasive, non-invasive method like MRE, like spleen stiffness or liver stiffness could also not only measure the liver fibrosis, could also measure the portal hypertension. So of course, this is a patient with hepatitis B. You can see this, of course, is a function of you can see that's the no viral suppression. There are no variceal esophageal varices. Of course, they're still very good after long-term follow-up. Another one, no viral suppression, and they already have grade 1 esophagus at the baseline. Then the progression, the portal hypertension will progress. With those in between, they have a similar the rate in between the two things. So that means that both viral suppression and the baseline liver stiffness determine the long-term outcomes, specifically the progression of portal hypertension, including the increased size of the varices. So now this is a measurement of spleen stiffness conducted by Professor Hou Jinlin's group. We can see, well, this is study actually very interesting. They see that patient on our antiviral therapy, if they fulfill the Baveno 6 criteria, that means LSM measured by VCTE less than 20 and platelet higher than 150, then that's so-called favorable bivalent 6 criteria. You don't need to do endoscopy. Safely avoid this. Whereas, according to this, if they have unfavorable ones, usually you need to do liver biopsy, endoscopy. However, here, if you measure the spleen stiffness, if they are higher than they are lower than 46, then you don't need to do endoscopy. If they're higher, do this. So by doing this, we further avoided endoscopy in part of patients. So this is also a very interesting study. So almost at the end of my talk, I would just like to show you the ALD guidelines. A little bit complex, but the idea is first, it's imaging modality for assessing liver fibrosis. Actually, first, they use FIBR4 or APRI or this kind of NFS or this kind of things. If they can divide into 3 groups, then they further use either ultrasonography measured ISM or MRE. If they have very low results, it's a favorite, this green one. On the other hand, if you have very high value of liver stiffness, of course, they have clinically significant portal hypertension. However, there's still some of the patients in between, so-called green zone area. Maybe these kind of patients, we need to close it follow-up, or we need to do liver biopsy. So this is perhaps almost the end. This last one. There's an issue guideline for portal hypertension. So idea is the same. If they have a very good profile, then you don't need to do endoscopy. If you have a very low value, of course you don't need to do that. If you're high, you don't need to do. If it's something between, you need to do endoscopy. Try to identify whether the patient have the clinically significant fibrosis. So very lastly, this is a bivalent 7 protocol rule of 5. You see, very interesting, very easy. They tried. Of course, this is not so accurate, but every increase in 5 kappa, then the clinical portal hypertension will increase. So this is clinically helpful to identify, to figure out the high risk population. Therefore, you can give the target therapy. I would like to thank you for your attention. So I will just finish my talk within 20 minutes. Last but not least, I would like to welcome you to APASO 2025. Then the president the president-elect is here, Professor Wei. Then we welcome you to Beijing with really a combination of our long history and the modern things. So I'd like to thank you very much again.
Thank you, Professor Josh. I think we're gonna have last talk, and then we have Q&A after the last talk. Last talk going to be given by Professor Kamal Chihar. Professor Chihar, are you there online?
Yes.
Okay, Professor Kamal Chihar is a professor of internal medicine at Mansouri University, Mansouri City from Egypt. He is among the founders of the hepatitis C eliminations with a successful success story of elimination. And today he's going to talk about the risk prediction models for predicting hepatocellular carcinoma in the patient with chronic hepatitis C after SVR with compensated chronic liver disease. Professor Chihar, please. Professor Chihar?
Thank you very much, Mr. Chairman.
Go ahead.
Thank you very much. I want to thank you for, and also to thank Professor Sheena, the president of APASL, for
Yeah. So this is fine. So there is a problem of internet connection. So it's just... Are you still there? You still freeze. We have been disconnected because of the network connections. Could you wait for a little bit? We're like taking some part of discussions. Okay. I'll tell you. So while we're waiting for Professor Chia, I think maybe we can go ahead with the Q&A for Professor Jitong Jiao and Professor Kawada. Let me start with Professor Kawada. You talk about usually after the treatment eliminating the cause of fibrosis. You talk about regressions of hepatic fibrosis. So is that the same between the term regression and reversal of fibrosis? It can be interchangeable, or it's not it's just the degrees of regression. Can someone with hepatic fibrosis and cirrhosis can return back to normal liver, absolutely normal liver?
Yes, thank you very much for your question. It's a very important point, as you may know. So I think in human case, if liver fibrosis stage is maintained in, for example, F1, F2, I think if in case of the early stage of liver fibrosis, after the treatment, for example, the eradication of hepatitis virus B, C, or control of hepatitis B, in such case, liver fibrosis can regress and return to almost normal situation. However, as you may know well, in advanced liver fibrosis like cirrhosis or decompensated cirrhosis, it is very difficult to recover to the normal situation because even after the eradication of insult like hepatitis virus B, C, still you see the remaining fibrotic septum, strong, very strong, thick fibrotic septum in the liver. So complete disappearance or regression of liver fibrosis in human case is hard to believe at the moment. However, we need the long-term observation after the eradication of virus or control of virus because at the moment we have had only 10 years interval after the initiation of DA treatment for hepatitis virus C. So if we see more long time, for example, 20 years or 30 years, I want to think, large amount of deposited extracellular matrix can be removed gradually by, for example, by the ability of matrix metalloprotease or apoptosis of stellate cell or myofibroblasts. So at the moment, I can say such things.
And you touch upon the cytoglobulin. Is the cytoglobulin just the markers of advanced fibrosis and that caused hepatocellular carcinoma, or it caused it just a marker, or it can directly effect on development of hepatocellular carcinoma, and are there any way to increase cytoglobulin?
Cytoglobulin is a marker for quiescent stem cells. So in case of advanced liver fibrosis, cytoglobulin expression is remarkably downregulated in activated or myofibroblastic stem cells. So in the absence of cytoglobulin, you see the occurrence of strong oxidative stress or continuous activation of stem cell. So it is not a kind of marker, but it is a very, very nice regulator or controller of stress cells. So we believe cytoglobulin is very important molecule to regulate the status of stress cell activation. Yeah.
Professor Jia, any questions from the audiences? Why while we waiting for the questions, Professor Jia, regarding the the ultrasound-based elastography, so you show us that the the VCE and also the point shear wave, it seems that the log curve is going to be better than 2D. Do you have any explanation on that?
Oh, sorry. Well, this kind of comparison, we have some comparison, but usually they have a similar results. But just because the VCT technology is more widely used and more widely validated, so maybe that's one of the reasons. Of course, for the ease of use, of course, I would say the VCT a little bit easy because they don't need to be operated by the physician in radiology or ultrasonography. You can, after very short training, you can do that. Maybe for the other one, you need to the operated by the radiologist or by in China we say imaging doctors.
And if the the result is low or in the in between in the gray zone, how often you follow in order to to reassess the progression?
Well, this is an issue of discussion. Now, some clinical trials they require that at least 2 times have consistent result. They can really accept it, because this is although we say it's the beauty of this technique is easy to use, simple, cheap, inexpensive, but actually the reproducibility is not 100%. So usually for clinical trial, I realized recently they ask maybe after 1 week or 2 week repeat. You can, if the two are very close results, then you be reliable. Otherwise, it would be difficult. In clinical practice, of course, I always explain to the patient, don't worry about this. We just this a new technique. We just see the overall trends, not the single time point results. So that's sometimes it's worrisome the patient. Thank you.
And since I don't think the availabilities of even the ultrasound-based elastography is not widely available. So in real practice, will you start with the ultrasonography based elastography, or you got to start with the the simple biomarkers like FIB4 or something before you go for elastography?
Yes, that's a very good question. Actually, you can see from the American guideline and the European guideline, actually the first screen with simple blood markers or so-called formulas. Then you can have that. Of course, that's we say now in China, at least in major cities or in the eastern part of China, it's widely available, but not easily available to every part, even within China. So I fully agree with you. Thank you.
Thank you. Now we have Professor Chiha back. Professor Chiha.
Yes. Sorry for the bad connection of the internet. I'm ready to
Yes,
give the
please
presentation.
go ahead. Yes, please go ahead and make your presentation.
Our talk about the hepatocellular carcinoma risk prediction score in chronic hepatitis C with patients with compensated advanced chronic liver disease after achieving SVR in chronic hepatitis C patients. Next slide. Hepatocellular carcinoma remains a major health problem as it is one of the most prevalent cancers globally, with a poor prognosis and a leading cause of cancer-related death, and represents one of the key challenges in the management of HCV patients nowadays. Next. The worldwide incidence is heterogeneous because of the variable prevalence of the underlying risk factors, and it is estimated that 72% occurs in Asia, more than 50% in China, 10% in Europe, 7.8 in Africa, 5.1 in North America. Next. And this is in many parts of the world, the incidence is related to the advanced fibrosis and liver cirrhosis. Next. The etiology is, as you know, is mainly alcohol, hepatitis B, hepatitis C, and others. And the common pathway is liver fibrosis, the advanced liver fibrosis, and the subsequent cirrhosis and its complications. Next slide, please. And the risk factors, as we mentioned, advanced fibrosis and its relation to obesity, insulin resistance, male gender and age, the genetic markers, diabetes, and lifestyle factors. Next. The incidence of liver cancer is increased by 70% from 1990 till 2015. This data reflect changes in etiology, population, age distribution, population growth, and during that period, this significant in HCC age standardized incidence was in many cases due to hepatitis C. Next. Next slide. Next slide.
Okay, we try for one more time. Then if it doesn't work, we finish. Sorry for the the issues of internet. Maybe you can. Yeah, the steering committee meeting. Okay, I take care of this. You are steering committee. You are. You need to present the progress. Right? The preparations and because you are the president, you're going to be the president. I'll join maybe half an hour and then I leave for So maybe if it doesn't work, it doesn't work. Okay, so I think maybe we can call the session close. I think because of the technical issues on connecting with the internet, and sorry for this technical issue for this afternoon. However, I think we have learned a lot from the previous two speakers regarding the fibrosis and assessments of fibrosis by non-invasive. I think if there is no more questions, I think we would like to call this session end. And thank you for Professor Waylight and our moderators, co-moderators, and thank you all of you. And sorry for this technical issue. Thank you.
Thank you very much, speakers and moderators. This concludes today's programs in Room 3. Thank you for your cooperation.
Can I continue?
I'm sorry, Professor. The chairperson has already closed this session. I'm really sorry for the inconvenience.
Okay, thank you.
先生が出るまでやりましょう。今の先生が出たら落としちゃって大丈夫です。
xong hồi đấy xong rồi no quá thì nhưng mà bên trong nó chỉ có 4 lần rồi nó có mấy rồi lúc đầu em tưởng là không có nhưng mà sau rồi về sau họ bảo em đã hội thảo xong rồi chuyển sang để làm cái ngay.
傘がいな、そうだ、落としちゃってください。